of our Monday research rounds session. And of course, I'm very excited in a moment to introduce the one and only Jennifer Reed, but I want to first just mention, remember that these sessions are hybrid, so we do have some attendees online. So for those online, as per usual, there's a Q&A function. I think there's a potentially chat function, and I think you can at the end, raise your hand and whatnot. And for those in the room, of course, just use your actual hands, etc. And there's a microphone in order to have those online be able to hear the questions. So whenever possible, use a microphone, or we can hand it around. So Jennifer is the program chair of the cardiac rehabilitation rounds, and she has been at the Heart Institute as a scientist and director of the Exercise Physiology and Cardiovascular Health Lab. And she's an associate professor in the School of Epidemiology and Public Health in the Faculty of Medicine. And she's also an adjunct professor in the School of Human Kinetics and Health Sciences, and a registered kinesiologist at the College of Kinesiologists of Ontario. So she's got a very long number of certificates behind her name. And I think anybody who's met Jennifer before and knows, and we'll hear more about that today, but really a passion for doing research in exercise and physical activity and helping those with cardiovascular conditions. And a lot of the work that Jennifer has done over the years with her team really has taught us sort of what is possible in the realm of physical activity and exercise and movement, and the importance of those in the various ways that we consider them in cardiovascular for our cardiovascular patients. So not just, exercise, all exercise is created equal, but actually there are different types and different ways to do it that actually are more successful and actually bring a lot of health to our patients. And that's sort of what Jennifer has been, and I'm assuming going to be able to tell us a little bit about today. And Jennifer is a very well-funded researcher, Canadian Institutes of Health Research, Heart and Stroke Foundation, Canadian Network, CanNet, the Ministry of Research, Innovation and Science. She's won many awards: New Investigator Award in Clinical Rehab from CIHR, an Emerging Leaders Research Award from Heart and Stroke Foundation, and a Young Investigator Award from the Canadian Society of Exercise Physiology, and the Robert Beamish Award from the Canadian Cardiovascular Society, which will be presented at the end of the month in October at the CCC in Vancouver. And we're excited to have Jennifer here, and I think her leadership in the cardiac rehab program has just been, so critical to the success of the program, not only in research, but also for the specific impact that her work has had on our patients. So thank you, Jennifer, and we're really looking forward to hearing the update today.
Well, thank you, Katie, for such a warm welcome. And it's so lovely to see all of you here today helping to kick off our first cardiac rehab. No? We're walking towards me. Get started. I can't see my colleagues online, but all systems go. So the purpose of this afternoon is really to reflect on the past year of my role as program chair within cardiac rehabilitation. I'm sure many of you here and online are familiar with our cardiac rehabilitation programs, but it's an opportunity to share with you what we've been focused on for the past year, some of our short-term goals, and then where we're headed in the future. An opportunity to perhaps instill some excitement and passion for those that are not as familiar to the field of cardiac rehabilitation, because cardiac rehabilitation is not only multidisciplinary. If you're a healthcare professional, you can likely find yourself within a cardiac rehabilitation program across Canada, but it's also multimodal, meaning that smoking cessation, physical activity, exercise training, nutritional counseling, psychosocial counseling, social work are all components of cardiac rehabilitation programs. And cardiac rehabilitation research has not only focused on the clinical execution, but also basic science. So it's a field that really integrates a diverse set of skills and experiences of scientists and also healthcare professionals. Following a quick whistle-stop tour of what is recent or most read or of interest in the field of cardiac rehabilitation, I'm going to spend some time discussing program goals, where I've been focusing the past year and where we're moving towards. And last but not least, as I just mentioned, where our program is headed, the big question. Very brief overview. It is well established. There's irrefutable evidence to really show the clear benefits of exercise-based cardiac rehabilitation. What I want to walk you through is some of the recent systematic reviews and Cochrane reviews that use a high level of robustness with regards to design in terms of evaluating the science as it pertains to cardiac rehabilitation. What we've seen for the past few decades and in recent reviews is exercise-based cardiac rehabilitation has been shown to reduce the risk of MI, all-cause mortality, and all-cause hospitalization, those with coronary heart disease. It's also been shown to reduce the risk of all-cause hospital admissions and heart failure-related hospital admissions. Again, has been shown to lead to a number of other clinical and patient-reported improvements, including health-related quality of life in those with heart failure and improvements in heart-related quality of life up to 12 months following cardiac rehabilitation in those with coronary heart disease. Where the evidence is less clear, perhaps unknown, is regarding the impact of cardiac rehabilitation on mortality, hospitalization, and health-related quality of life for adults after heart valve surgery. Whistle-stop tour. I'm curious, I can't pull the virtual audience as well as I can the in-person sitting here today, but how many of you, for the publications that you typically read or cite, how many of you often look through to see what's the most read or the most cited publications for those particular journals in your field? This up is, many of you may not know, but somewhere at the bottom pages, the bottom of the pages of most peer-reviewed journals, they have sections devoted to most popular articles, most cited, and most read or downloaded. And I always find these sections interesting because it gives an indication of perhaps where the greatest need is in the field, and therefore that's why the uptake may be greater for those particular publications. But it also gives you a clear sense of the interest of scientists and those working in the particular field. So I always like to keep an eye on these sections within the journals that we typically publish in or we aim to publish in. So I'm going to walk you through a few of these publications that have come out in the past year across circulation, JCRP, which is the only professional journal dedicated to prevention and rehabilitation, Canadian Journal of Cardiology, which is likely known by many of you online and in person, and the European Journal of Preventive Cardiology, whose impact factor now sits close to 10. And I know my colleague, Dr. Kelly Kilby, will say it's not only impact factors. So I state that because I know that it's not the only metric, but hopefully this does indicate the robustness and the quality of the publications that continue to come from EJPC. I want to highlight is in circulation, cardiovascular quality and outcomes. And this was a network meta-analysis of 81 randomized controlled trials that was published 2 years ago. It's in the section for circulation as most read and of interest, and that's why I've pulled it here today. What they've done in this particular network meta-analysis is to review modalities of exercise training for those that are overweight and obese. And I pulled this particular article because I'm familiar or aware that the UHI has an obesity guidelines committee, and this particular publication may be of interest to this committee or those that work in this field, as it is a grave concern amongst our patients. What they particularly evaluated or compared was the effects of continuous exercise training, CET, most days of the week, 60-minute sessions, continuous nature of moderate to vigorous intensity. They compared it to interval training, higher intensity, shorter duration of the specific bouts of exercise, to resistance training several days a week, and then combined training, a combination of continuous exercise training and resistance training. And the last form of exercise training, or the last type of exercise training that was included in this network meta-analysis, was a hybrid form of exercise, functional training that combines both strength training and continuous endurance forms of exercise. The publication network meta-analyses are certainly no small undertaking, but what they showed in terms of the impact of these different types of exercise training on a number of cardiometabolic outcomes was that combined training using continuous exercise training in combination with resistance training had the greatest impact on a number of cardiometabolic health outcomes in those that are overweight or obese. To attention, and also aligns with, we had a recent systematic review that was published in the British Journal of Sports Medicine. This journal fares very well in our field. It's highly regarded. It was led by a prior postdoctoral fellow, Dr. Tasuku Turata, who's currently an assistant professor at the University of Nottingham in the UK. He led this systematic review and led it extremely well, that we are very pleased to have it published in the British Journal of Sports Medicine. But similar to the previous publication, this shows a greater increase in this case, cardiorespiratory fitness when we employ combined versus aerobic training alone in terms of exercise training for those with cardiovascular disease, and a greater increase in, or greater improvement in, body composition, specifically fat-free mass, when we use combined aerobic training plus resistance training than aerobic training alone. These two publications are important to highlight because far too often patients don't engage in resistance training, or it's a last component of our programs that lasts just a few minutes. There are a number of perceived barriers to resistance training, including the inability to measure repetition maximums. There's fears from patients regarding resistance training, and often there are the unknowns of how to properly demonstrate and execute a number of resistance training modalities. So I highlight these publications because clearly this is of interest in the field, but it also speaks to the evolvement or evolution of what we're offering in our cardiac rehabilitation programs. To highlight is in the European Journal of Preventive Cardiology, and this is a systematic review and meta-analysis that focuses on cardiac rehabilitation and frailty, a very prominent, dominant concern within cardiac rehabilitation programs, and not only within the sphere of cardiovascular disease, but all chronic disease populations. We see frailty admission of 40 to 50% in the patients in this particular study that included almost 20,000 participants across 34 included studies. And this particular review highlighted that cardiac rehabilitation is feasible and effective in improving frailty in those with cardiovascular disease. It also has been shown to reduce all-cause mortality risk in those that are frail. And so it really does provide a venue or an opportunity to consider frailty within our cardiac rehabilitation programs for those with cardiovascular disease. How are we assessing the prevalence of frailty when indeed it's been shown to be 40–50% of those enrolling? And how can addressing frailty, and specifically how can the enrollment in cardiac rehabilitation address frailty concerns within our populations? This year in JCRP, the Journal of Cardiopulmonary Rehabilitation and Prevention, has shown the impact of cardiac rehabilitation on up to 180-day all-cause hospital readmission and mortality, clearly showing in a few thousand patients that were included in this single-site, highly controlled retrospective observational study that cardiac rehabilitation can in fact reduce these important aspects of patient care. Highlighted, although the lines may be difficult to see based on the size of the figure, that it's the cardiac rehabilitation group that substantially benefited, but also that these effects were seen up to 180 days, which is approximately 6 months, just by enrolling in a component of cardiac rehabilitation. I will want to highlight again, and this was within this work that I'm highlighting has been published within the last year, and already these publications are being widely read and cited within various fields. This one particular that comes from our work here at the University of Ottawa Heart Institute. It's a 3-arm randomized controlled trial that compared Nordic walking, high-intensity interval training, and traditional moderate-intensity continuous training, your standard form of cardiac rehabilitation. This is a follow-up publication to our initial RCT that compared baseline to follow-up, but in this particular publication, we looked at the continued or sustained effects of cardiac rehabilitation on patients with coronary artery disease. This was led by Dr. Tasuku Terada, a former postdoctoral fellow here at the Ottawa Heart Institute, and this publication is going to be receiving the CCS Robert E. Beamish Award from the Canadian Cardiovascular Society at the end of next month. This publication, as I mentioned, was a randomized controlled trial, included 135 participants. And what it showed was that Nordic walking led to greater improvements in functional capacity at the end of the trial, at the 12-week time point. But not only did it lead to greater improvements in functional capacity at the end of the trial, these effects were sustained and observed up to 26 weeks or at the 6-month time point as well. So this generated a lot of interest across the globe, from podcasts with the BBC to interviews. I've been forwarded information regarding this publication, and more than 20,000 downloads of this publication have occurred since initially published. So I think it continues to speak to the interest in looking at a variety of modalities. One size clearly does not fit all, but also I think we conducted this trial extremely well, running a randomized control trial with trying to minimize as much bias as possible at every level, from recruitment to the assessment phase. Of these articles, why show you the trending articles or those that are valuable? I think it sets us up really well for discussing, my mission as the program chair for cardiac rehabilitation, what the focus is of the program from a scientific direction, what our short-term goals are, and again, where we're headed in the future. Overall, the chair's role is to innovate, develop, implement, and evaluate programs designed to prevent and manage heart disease. My key focus is to build an internationally known cardiac rehabilitation program, and that program of research which will inform patient care. Model that really guides a lot of the decision-making within our program, and perhaps an opportunity for you listening to this presentation to think about how your own programs fit into the larger divisions or within the Institute, and those that you might connect with in terms of your collaborators for various projects and initiatives. We see it as care at the Institute begins with research. So care begins with research. And with that, we have a focus on cardiac rehabilitation, but that focus of cardiac rehabilitation is not isolated. It works with other programs or initiatives within the building, within our Institute. And that includes our heart teams, our Oracle hubs, our Cardio Core, our Data Science Center, and the Canadian Women's Heart Health Center. We work collaboratively across these programs for a stronger, more robust, more impactful cardiac rehabilitation program. I set the scientific direction, and then that leads to the evaluation, to evaluate the effectiveness of our program offerings. We have essentially a buffet of offerings for our patients. We hope that regardless of who you are, and if you're seeking cardiac rehabilitation, we have a program that will be of interest to you or feasible for you. And whether that is a French-only program to those that are hybrid in nature or fully virtual, we try to offer something for every patient. And that comes with consultation from our healthcare professionals at the intake process of our program. But these programs need to be evaluated. The launch of a program does not mean the continuation of a program for decades to come. Our patients are more complex than they have ever been. Our resources are changing, funding models are changing, and that requires due diligence on our part to ensure that we're continually evaluating our programs to ensure not only that they fit within our patients' needs, but they're efficacious and they're effective for the long term. Those evaluations of our programs will then, as I mentioned, inform current and future programming. And then, of course, what we want to do is to move those evaluations out, our research outputs, in terms of presentations, publications, and other knowledge translation events. And then this circle continues, and it's our model that we use to help guide our day-to-day activities and our long-term strategic vision. beyond the 4 walls of this building. Maybe with renovations, we're looking at 6, 7 walls, but beyond the walls of this building, we can't remain isolated, and therefore we need to go out of the doors and interact with our patients and our patient partners. We have implemented these cardiac rehabilitation rounds, and aside from myself, all of our speakers are international. That's part of the programming. We also connect regularly with the foundations. Leanne Lang is doing an absolutely fantastic job with her foundations team, and so we want to keep in close collaboration with their initiatives so they can be aware of the research that we're producing. And we also want to become more involved in national and international registries and collaboration. It's the future for us producing high quality research, but it's also key for us ensuring that we have a place on the map long term with our partners. Or short-term goals in my first term as chair? Well, the first is to establish, or was to establish, a cardiac rehabilitation heart team. And I co-chair this with Bonnie Quinlan. The two of us work together to design the goals of the cardiac rehab heart team. Our overall goal is to strengthen research, education, and clinical collaborations and engagement. It's a multidisciplinary membership. We have 28 members, and that's not a final end. If you're interested in being part of the cardiac rehabilitation heart team, please speak to your manager to see if we have representation from your specific discipline. But we really do recommend the multidisciplinary aspect, because cardiac rehabilitation is multidisciplinary. We need all voices, all experiences, all skills within our team. We also have a number of patient partners and very active patient partners within our heart team. Our goals for 2023 and 2024 were to develop an inpatient prehabilitation program, was to also develop a cardiac rehabilitation program for those from Nunavut, and to do a robust evaluation of our suite, our offerings of cardiac rehabilitation. Be quite familiar with our prehabilitation surgical program. This consort shows the flow of our prehabilitation surgical program. I'm not going to go through every box of this. The figure is meant to show you that A, we have such a program, but B, I want to highlight that those that are assigned or deemed appropriate for elective cardiac surgery, they have the same day referral to our cardiac prehabilitation program. And I think this is an extremely wonderful initiative that's been ongoing for a few years. Bonnie Quinlan has been steering this with a very steady hand for a long time, with integration of our healthcare professionals, our surgical team, our rehabilitation team. But we've had a program that started years ago where there wasn't much. We had a program, but it certainly wasn't to the extent that it is now. Surgical program, there is an assessment or an evaluation as part of questionnaires, and these are the components that we assess using a series of questionnaires. We also administer the SF-12 at baseline and follow-up, which is a general quality of life tool, but you can see the robustness of the evaluation across our multidisciplinary teams. 2023 and up to April 2024, we see approximately 80 to 120 new patients monthly, and on average are following 300 patients, including biweekly symptom screening. So this is not a small undertaking. There's a lot of work that goes on to offering this program, but also supporting the patients that are waiting and those that are currently enrolled in the program. A systematic screening and continued care platform for prehabilitation that's provided by the nurses within the building, that the patients receive screening calls biweekly until their surgery or procedure date. If symptoms are worsened, we have a path for escalation, and we also have contact numbers for patients if there are any concerns or questions. Our established prehabilitation program for elective surgery, because it sets up very well for one of the goals of our cardiac rehabilitation heart team, and that is the implementation of prehabilitation for the inpatient. And this initiative is being largely led by Amy Charlebois, who is a nurse within the division, but of course there are many other individuals that are involved in this process, but this will be launching soon. Amy has indicated there will be a wait list, but now our patients who are inpatients will have the opportunity to go through a prehabilitation program. So sharing this with you, as it is a project currently in progress, but more information will certainly be coming soon as it's released. initiative that is a component of our cardiac rehabilitation heart team, but certainly at the institute level as a whole, is increasing enrollment of those from Nunavut into our cardiovascular rehabilitation programs. These are marginalized populations, not often provided access or included in life-saving secondary prevention programs such as cardiac rehabilitation. And currently we have a goal of increasing enrollment of patients from Nunavut by 50%, a very lofty goal, but these are numbers from 2023, 2022, my apologies, in 2023, showing you some of the early days of the patient enrollment. A nurse who's been working tirelessly on this initiative. I've seen presentation files of hers when prepping for this particular presentation. They really have thought of a number of different initiatives to increase their enrollment. And so these are the various approaches and strategies, including systematic measures, referrals made, community partnerships, bi-weekly rounds by cardiac rehabilitation nurses on units to meet with the patients, monthly Excel tracking, and resources provided in English, and of course their spoken language. If you have specific questions regarding these programs or want to learn more, please don't hesitate to reach out to myself or certainly those that are leading these initiatives to provide more information. Although this may be specific to cardiac rehabilitation, the inclusion of marginalized populations or underrepresented groups is not only an issue for cardiac rehabilitation, it's an issue for all clinical trials across the board. Initiative that wasn't part of our initial short-term goals for our team, but this is our Sharing is Caring event that is a knowledge translation event that came from the collaborations and the engagement with our heart team. The title of this, Sharing is Caring, for some of you, you may know I have 2 toddlers at home. I have now a 3-year-old and a near 5-year-old, and sharing is caring is often a motto that's mentioned very often in our home. So what better title to use for a knowledge translation event when we're talking about sharing our research with patients, with patient partners in the community? So Sharing is Caring was an event that was launched last year. Bonnie and I co-chaired this event, and of course we had a subcommittee that was highly involved in planning this. Dr. Karen Bouchard, who's an associate scientist in the division, was really a large force of expertise and resources for helping to design this initiative. It really speaks to the importance of education and how we provide education, in what venue, and how to seek feedback from patients in order to educate ourselves on how to improve for future events. So Sharing Caring, what specifically was it? Well, if you didn't attend, it was a knowledge translation event where we shared research outputs pertaining to cardiac rehabilitation, focused on physical activity, smoking cessation, the role of psychosocial health, and patient partners or partnerships in general in terms of the role of cardiovascular care. We shared outputs, research outputs, in a very lay format. We launched the event with only 4 weeks to go, and we had over 200 registrations. It was a very well-attended event that was, I'm so happy, with the outcome, but this was largely, the burden was shared by communications and research services who made all of this possible. And here's just a few photos of the event. So save the date, we plan to repeat that. The feedback was we want to have this more than once a year. I can see how valuable the event was, but based on some of the resources that we have decided to repeat the event next February. So February 2025, we are going to begin identifying speakers for this Sharing is Caring event and replicating a lot of the methodology that we used last time around, but with improvements. Included as well for our short-term goals, I had mentioned, is we're going to do a robust evaluation of our cardiac rehabilitation programs. We have had electronic data capture for almost 20 years within our rehabilitation program. And so there's no better time like the present to evaluate the prior programs. And some may say, why evaluate programs that are no longer offered or perhaps no longer of interest? Well, we need to do that so that we don't continue to offer programs that may not have been as efficacious or effective as we once hoped. And there are lessons to be learned from prior programs and current programs that set the stage for future programming. We not only wrote a proposal, we secured funding through a precision medicine call, and then we recruited Dr. Matthias Hausen. I don't know if he realized the extent of one of his major projects for his postdoctoral fellowship, but he's certainly taken this task in stride and ease so far. And so we recruited Matthias from Brazil. I think I'm one Canadians in my team. I think we more so have a Brazilian team now. But he is at the helm of leading this project. Our primary outcome for this specific project is to describe the socio-demographic factors, including gender-related variables and clinical characteristics of patients enrolling in and completing cardiac rehabilitation programs. But where the true value of this information lies is not necessarily those enrolling, it's those that have not enrolled. By knowing who's in the programs, we'll have a clear idea who's not in the programs. And those are the individuals we want to target. Those are the individuals that are at greater risk for cardiovascular disease and for secondary or tertiary events. So with more than 20 years of electronic data capture and somewhere north of perhaps 30,000 patients, we'll have the ability to look across all of our program offerings or streams and to get a very detailed view of our patients enrolling and completing. And these are really a few of just a larger program of research that Matthias is developing. What we want to do is compare enrollment rates across the different cardiac rehabilitation programs or offerings. We want to assess the effectiveness of these programs for improving physical and mental health outcomes. And of course, we can not only focus on physical. My good colleague and friend, Dr. Heather Tulloch, would say mental health is just as important, if not more important. So of course, we will include a very balanced, comprehensive assessment of our programs. And also that speaks to the expertise that we have within house. We have a number of clinical psychologists that are key to the programming, and we also want to evaluate for their own benefit to see which of the programs that they've been offering for years past are having value for our patients. And lastly, but not really lastly, is to explore the predictors of enrollment and improvements in physical and health mental outcomes. Now brace yourself for this next slide. It's not made easy for you. And therefore, there's a reason. So Matthias has undergone, since starting here earlier in this year, a data mapping exercise of all of the potential variables and databases we are going to need to access, integrate, merge. The terms will go on. I'm not a data scientist, and I'm going to leave that in the very capable hands of Matthias and our data science center. But this is a very complicated process, and it's taken him months to do because we don't have a data dictionary, a clear data dictionary for all of the variables that we've been collecting for 20 some years. We know the information that we're collecting, our patients know it, our healthcare providers know it, but we don't have a robust data dictionary. So then to go to our data center and indicate we need, these 500 variables exported, they're asking us what those variables are. And this has been a very large task. But hopefully by us undergoing this process, this will provide opportunities for others in the building to undergo a similar process if they're interested in using this data for evaluations. So we plan to connect across a number of platforms, both within house and out of house, to evaluate our pre-post outcomes focused on physical and mental health, but we also plan to look at MACE, major adverse cardiovascular events. And yes, there's a time note here of 5 years, but we certainly are going to go beyond that time limit based on the available data. As I mentioned, we anticipate there are going to be several manuscripts, and it's been given in updates in the cardiac rehab heart team because I'm hoping that by us regularly presenting the updates in this project, it's going to entice other individuals to reach out and get involved. There are too many manuscripts to be written. There is a very large data set, but I believe a data set that will have a lot of value. So regardless if you are focused on heart failure or those with devices or arrhythmias, certainly we want your expertise within these manuscripts, and it's a way to really open the doors for future collaborations or more in-depth collaborations. On this tour of short-term goals, I don't think I made it easy on myself, but I think we are certainly delivering on most, if not all of these already within the first year to two, is we want to become part of the ICCPR, the International Council of Cardiovascular Prevention and Rehabilitation. This is an international registry for cardiac rehabilitation. And in Canada alone, there are 400 cardiac rehabilitation programs. So if you think of Canada alone as one country across the globe that offers cardiac rehabilitation programs, if we contribute to this registry, that will enable us to have access to data across the globe for further evaluations and collaborations. We have been invited to join this registry process, and we have had a number of discussions regarding planning for how to contribute this data. Based on their current infrastructure, it is more of a manual entry because it has been set up to also encourage those from lower socioeconomic statuses or underdeveloped countries, I should say, to add data to this registry. And so not every country is going to have the technology that will enable them to add their data to the registry. So it's a bit more of a manual process at this point. So what we are doing in the interim is we have been working with the Canadian Association of Cardiovascular Prevention and Rehabilitation. They have an online registry, and this is something that my close colleague Jennifer Harris has probably been wanting to do for much longer than I have been at the Institute, but she has been fearless in advocating for the sharing of our data and the involvement in the CACPR registry. So we have had discussions with Dr. Jody Edwards and Dr. Kelly Colby regarding how do we move this data into our integrated databases and then to share with the registry. So those discussions are ongoing, and I believe we are the first beta test for this process. So this is really exciting to us because it's a path to not only contributing our data for much more meaningful evaluations, but also opening the doors for other collaborations across the globe for the Heart Institute. Short-term pieces is establishing rehab rounds. Well, I think we can check the box here. You're sitting at rehab rounds. This is our second year. There's a huge force here to engage clinicians and researchers, and there's a requirement to be invited for rehab rounds that they're international speakers. We want to have a greater picture of rehab across the globe. It's also an opportunity to share the work that we're doing, but also really to understand better what's being done outside of our building. These are open to anyone, faculty of medicine, faculty of health sciences, anyone across the globe. And in fact, that is what we've had. So last year, I'm sharing with you, if you didn't have the opportunity to attend, most of these lectures are recorded, aside from one where there was a technological issue. But we had registrations on the lower end of 137, and on the higher end, we had registrations of 414 for rehab rounds, which often doubles or triples our usual volume on Monday. And I won't look at the numbers today for me, but let's just not count me in this. I'm obviously domestic, local, but we had a lot of interest across these rounds. We do them every other month from September to May. And what we can see is a growing of international interest within our rounds. And so I've provided here the percentages of our international registration. So I know that we have colleagues in Japan that stay up until 1 a.m. in the morning sipping coffee, waiting for our rounds to start before they can go to sleep at night. And really focus or advertise our rehab rounds in November. Dr. Barry Franklin is, I would call him the godfather of cardiac rehabilitation. He has written, co-authored, edited over 700 scientific publications. He has 27 books that he's published and given over 1,000 invited presentations across the globe. We happen to be from the same university. We graduated from the same kinesiology program at Penn State University, and he's gone on to have very substantial global impact within cardiac rehabilitation. If you read any of his publications, you'll understand the high quality that he has put forth in his work to date. He will be in person in November, and I would encourage you to save the date in your calendars to not only come to rounds, but Dr. Franklin has also published this book, GPS for Success, that's been really well received within the field, and we're hoping to set up a separate presentation for this specific book and with trainees. So regardless of the discipline, basic science, clinical sciences, I hope you'll find value in meeting Dr. Franklin and coming also to this talk that's going to focus on GPS for success. Our short-term goal has been really focused on women and cardiovascular disease. We wanted to secure funding for the first only women's exercise and heart disease trial, and we did that first funded by Heart and Stroke. then funded again by Heart and Stroke when it was no longer the impacts of the pandemic, and then we received additional funding from CIHR. This trial is virtual only. We are addressing known barriers to women with cardiovascular disease and women enrolling in cardiac rehabilitation. Aside from the baseline and the follow-up measures, the intervention, the exercise training interventions are delivered entirely virtual. We're bringing the intervention to their home through Zoom for Healthcare, web cameras. They're required to have their web cameras on. We've thought through hopefully every level of detail when it comes to safety, including ensuring they have their doors unlocked when the sessions are occurring in case there is any adverse event. We are quite proud of the funding that we've received. This was done by a larger team really focused on this area of research, and we've just received ethics approval with this second bout of funding. Why do we care so much? Well, there are a variety, a multitude, myriad of reasons why. PhD student who is in the audience here, Isabella Hochmarsal, is a very well-funded and successful PhD student that's been with me for a few years, and she's just completed this rapid review. So this rapid review is looking at the inclusion of females or of women with cardiovascular disease that have undergone an exercise-based intervention. Could be cardiac rehabilitation, could be exercise training alone. But what she's shown from 2013 to present, and if you wonder why 2013, that was the year that CIHR implemented sex and gender considerations for grant proposals. So we selected that specific year to see what has there been any change in the proportion of females versus males included in clinical trials in this particular area. And sadly, there has not. So we see that the proportion of women is about 34% compared to 66%. We see a few years where the enrollment or inclusion is higher as a result of 1 or 2 trials that included females only, but females on average still only comprise about 34% of clinical trials in this particular field. And I don't think that this information or this data is going to be dissimilar than many other fields of study. On our women in cardiac rehabilitation research in the past few years, certainly since I've started. We were featured in Physiology News magazine a little while ago. They did a feature article on the work that we're doing regarding women's heart health in the space of cardiac rehabilitation. We had the opportunity to highlight and to celebrate a number of the trainees that have come through our program and now have gone on to set up their own programs focused on women's heart health, including Dr. Carly O'Neill and Dr. Kimberly Way. I also this summer spent time in Australia presenting on our cardiac rehabilitation results or data from our clinical trials, but also several specific publications on women's heart health and exercise training. CJC this coming year is going to have a special issue on sport and exercise. I was involved in the planning of this special issue, and we have a number of publications that will be focused on sex or gender within this call. I'd like to highlight the fact that we just completed a very exciting project with the Public Health Agency of Canada with Dr. Stephanie Prince-Ware and her colleagues. We spent the past year looking at the physical activity levels of those with cardiovascular disease compared to those without cardiovascular disease using some of their large national surveillance data sets. And we've also done a sex-based analysis within this work. We're hoping this will be published in the special issue. If it doesn't get accepted, then we will hope to find another home for it. But we're really excited to share this sex-based work, but also the first ever evaluation of the physical activity levels of those with cardiovascular disease in Canada using this robust surveillance system. Term goals, and certainly we want to move on to some of the long-term goals. And with that, I want to feature 2 publications that have been released into the literature in the last year or 2. And one is from Circulation, and the other is from New England. This is the particular New England publication. Both of these publications really highlight the need to deliver long-term, high-quality cardiac rehabilitation for all eligible patients. This is a theme across current calls to action for cardiac rehabilitation or lifestyle-based interventions, is that we need longer-term solutions, but we also need longer-term evaluations. Far too often our trials evaluate outcomes at the end of a trial and maybe perhaps 6 months, but longer term, where are these patients 1 year, 2 years, 10 years following these interventions? published last year actually highlighted research priorities. And I'm happy to see that a lot of our short-term goals and long-term goals align with what has been proposed by these particular authors in this publication, but that is certainly including more diverse populations, leveraging and implementing methodologies that use technology, underrepresented groups, and evaluation of more hybrid or virtual trials. Few minutes that I have just on where we're going long term. And there are three key elements I want to share with you. One is we want to establish a framework for regular evaluation of cardiac rehabilitation programs. And yes, I say the word cardiac rehabilitation over and over again, but this is not unique to cardiac rehab. All of our programs should hopefully be undergoing the same kind of robust process. But we hope to use a framework, the REAIM framework, to identify the interval evaluations, key primary and secondary research questions, the data analyses plans, working with our methods center, our data science center, and of course, ensuring that we have spent substantial time focusing on knowledge translation. We can do all of this work, but if this information, if this data doesn't get shared with our patients, how do these patients benefit? Very few patients are going to read peer-reviewed publications or attend academic conferences, such a small proportion. And we can't simply leave the data sharing of this to the individual physician visits that happen for patients, maybe once a year or maybe less frequent than that. So our knowledge dissemination plans need to be well thought through, they need to be robust, and they need to leverage the expertise in education that we have here in the building, which includes Dr. Karen Bouchard. Apologies, Karen, I'm for sure signing you up to be on everyone's knowledge translation section of the grant now. So another thing is I feel very passionate about is to develop a trainee program. When a trainee enters the building, what is our program for them for training? And we obviously fare more on the clinical research side than we do the basic science, but that doesn't mean it needs to be unique. We, with Matthias, who's recently joined us, we have set up rotations for him to spend time with multidisciplinary members of our cardiac rehabilitation team, so he can understand what's happening on the front line with our varied members. And then that will inform the research questions that get asked. Our training program, what does the number of publications or presentations look like? What are some of the goals for targets? We want to be a leader in this training space, and I think we have all of the tools needed, but we don't have a rigorous program yet in place, and I hope to work on that. I'm very excited to share with you that not only do we have Dr. Matthias Hausen, who joined us in January, who was the recipient of the Jenny and Craig Dowd Fellowship, we have 2 additional fellows joining us. So Ariane Vieira, another Brazilian to the group, she was awarded a CHR Health Systems Impact Fellow and scored very, very well in the competition. So she's going to be working with myself as the program. And then Dr. Heather Tulloch is serving as the academic advisor. So we're going to be teaming up with Ariane for this Health Systems Impact Fellowship. And then joining me in November will be Dr. Lindsay Liu, who's been recruited from Queen's University, who also did very well in the top 5. Both of these females ranked in the top 5 of the CIHR competitions. And hopefully Michelle's going to shake her head no if I'm mistaken, but I'm pretty confident on those numbers. But Lindsay Liu was awarded a CIHR postdoctoral fellowship. So we will have 3 fellows dedicated to building the capacity within cardiac rehabilitation. We also want to focus on creating a revenue generating stream. I feel very passionate about offering long-term assessments for our patients. When they leave the building, it shouldn't be in the end of assessments. And all of us know far too well that not every patient has a family physician. Not every patient is going to see their cardiologist on a regular basis. But offering or having programs where we can do regular long-term evaluation of outcomes not only will benefit the patients, it will expand our portfolio for evaluation and also feed into these novel integrated databases where so much energy and resources have been spent. So I've had some excellent discussions with Adam Dim from the innovations team as recommended by Dr. Beeland. So it's been a great discussion so far. So I am flipping through these slides because what I want to end on here is the focus overall of this program is high quality clinical trials and data sharing. Those are the 2 areas we're focusing on. Currently in our portfolio, we have 6 to 8 clinical trials ongoing. These are not small efforts. Behavioral trials require blinding, addressing risk of bias, many team individuals, complicated meetings where you're asking people to leave because they're blinded. But we feel that we can do this really well within this building. And if you think of the pyramid of the quality of evidence, that's where clinical trials sit. The other is data sharing. We want to continue to share our data, but becoming part of the registries, both the Canadian registry and the international registry, will enable us to, again, expand our research profile. We cannot continue to keep the data only in-house and feel that we can really make strides in this area without sharing data. And then, of course, if others take the same mentality, then we will have access to theirs. This slide, I did not have room to include everyone, and therefore the names are very small, but we have an amazing team of staff and trainees and student volunteers and interns. We regularly take a number of student interns on in the summer to help with our capacity. And of course, my long list of collaborators, some of them I have been with since the very first day. Dr. Andrew Pipe and Heather Tulloch and David Burney, I probably spent way too much time in their offices over the years, but I'm thankful for their mentorship and their guidance and their ongoing support. And of course, as I mentioned, the list here certainly is not the complete list. I call it a starter list because if you've been excited by what I've shared or the goals or the future vision, please don't hesitate to reach out because we would certainly love to include your expertise and skills with our program of work. Slide, because I think it summarizes many aspects of what we do and how we do it.
Excellent. I have a question regarding, you were talking about prehab. Mm-hmm. And obviously, as you rightly pointed out, there's so much about, the prevention and rehab side that starts here at this hospital, which of course is already very late in the process. So thinking about your vision at the end, do you kind of see it also as reaching earlier in the cardiovascular disease journey? So reaching younger individuals, have you thought about that, or is that part of, some of the applications you're thinking of for your future?
Yeah, that is a great question. When we were actually designing the women's trial, we considered having two groups, one with existing disease and one at risk of cardiovascular disease. And we didn't put it in the grant because I think it would have been ultimately too complicated at that point and how to best answer the research question. But we certainly do have an interest on the prevention side. And I know within the Canadian Women's Heart Health Centre, Dr. Carrie-Ann Mullen, certainly an area of interest to her as well. And they've been doing work in this space, their Cardio Prevent program for many years. I always come back to, we use secondary prevention because we're trying to repeat. We want to avoid an individual returning to the hospital for a procedure, change in medications, a variety of reasons, but we don't want them here to begin with. Right. And I know that that's hard to hear sometimes, but we really don't want these patients here. Yeah. We know we offer formidable care, but we want to really move it, that we're avoiding a lot of these patients having to undergo these very traumatic experiences, whether it's procedures or, the barriers and the difficulty with rehabilitation programming. But I do think we need to spend more time on the preventative side. Yeah.
Great. Not monitoring. Dr. Beanlands has a question.
Sorry, I missed a bulk of the presentation, but I will ask some questions.
Okay, now I'm nervous.
So in the clinical trials, I totally agree with prioritizing that. Yeah. How many, you said you had 8 at the moment? How many of them are multiple centers?
That's a great question. I know where you're hopefully going with that. These are all single center. There was one that was 2 of them were multi-center. One we've completed, one the other group had to drop out. But those clinical trials are largely single center. We do have a trial. It's an observational study that's across Canada. It's called CAN-SURVEY-AF. It's a 5-site trial, but an observational trial where we're assessing patients with atrial fibrillation, their physical activity levels, and they're also wearing wireless ECG technology. We certainly want to expand in that capacity. I think that's where you're leading me, but I'm going to let you finish asking your question.
Yeah, no, you've done such amazing work. And obviously it's far-reaching as you're going to present your data to multiple centers around the world. So the power of the multi-center trial is basically you get the volumes. Mm-hmm. So you can now start to look at harder outcomes because of that. So I wouldn't, obviously you can't do that for every single study. It's a lot of work to do that. But to me, it's a potential next step. So out of your 8, then maybe it becomes 10 or 12, 1 or 2 of them to try to be multi-center. Yep. would be awesome. And, you know, obviously answering fundamental questions. Yep. My other question is, how do you deal with and approach include vulnerable populations? Yeah. In the studies, and how do you ensure that they're well represented?
Yeah. Great questions. I'm going to come back to the one before. Our Women's Exceed trial, which is our virtual trial, that is the one we certainly have plans to do multi-center. Because the intervention's delivered virtually, we feel we can control the intervention fairly well from a quality or a quality point of view. And so that will be one of the first ones we try to launch in a multi-center, but not only nationally, but internationally, given the work that's been done so far. With regarding vulnerable populations, we certainly have had many discussions about how to increase the enrollment of our underrepresented and vulnerable groups. In our recent trials, they've been funded. We've gone as far to, so there's a few strategies we've used. One, if our patients do not have access to internet, we provide them devices and access to internet. There are a variety of companies that allow you to click in with a card into the device. So if you live somewhere north where access to internet may be a challenge, or you certainly don't have the funds for it, we're providing that and the devices. The other strategies that we've used is we are building in, and we have done it for past trials and will continue to do, funding support for childcare. So if you're not, and I'm speaking specifically to women, but obviously this is generalized to any patient who may have children. If you cannot come on site or be involved in a trial because of caregiving responsibilities, whether it's children or parents, we provide funding for that, vouchers for that, so they can seek other forms of care which will allow them to participate in trials. So giving them access to internet, giving them a device such as a laptop or iPad if they don't, and accounting for other responsibilities that may keep them from participating in a trial is part of our strategy. The other is we go even back to recruitment, and we look at our recruitment methods, and the virtual trial addresses some of those barriers by not having them come on site, but recruiting outside the building as well, and using some of our partners within the community that may see more of these vulnerable populations and working with them to advertise the trials that are ongoing. It's a lot more boots on the ground. I always used to keep a stack of flyers, and anytime I went to a grocery store or somewhere in a different neighborhood, I would be that person, you know, tacking up a poster for a trial. But I think it's what we have to do to increase our reach for those to be aware of the work that we're doing.
Say congrats to everybody here in the prevention and rehab program. I mean, you have an awesome leader. I think you know that in front of you, but it takes a team, and you guys have an amazing team that really is doing world-class research, and it's a pride point for the Institute. So everybody here should be proud of that and all the work that's being done. That was the only other point I wanted to make.
That was worth running. I also wanted to just add that I think, Jennifer, a lot of what you articulated today, and I think, you know, not stealing the thunder from Dr. Beanlands in the future, but, you know, is going to be integral in how we build continue to build the Institute, right? I think we're all in agreement that the work that you have done and the work that you continue to do is really integral to how we want to impact, you know, the cardiovascular health of our patients, our community, you know, et cetera, et cetera. And I think, you know, the roadmap you've followed now, as well as the one that you're planning on following, really aligns with that. So I think we're all really excited, and we're excited for November 18th for your speaker. And if there are no other questions, I will conclude. Thank you, Jennifer. Thank you, everybody.
Thank you.
Take care.